Welcome to the deep dive. Today we're tackling a really interesting and kind of mysterious condition, Takayasu Arteritis, TA for short.
Right. Think of it as the immune system sort of misfiring and targeting the aorta, your body's main highway for blood and the big arteries branching off it.
And we've pulled together insights mainly from medical textbook excerpts for this, so we're aiming for a pretty comprehensive look.
Exactly. And what's really intriguing, I think, is the history. You find descriptions hinting at TA going back centuries, but the exact cause, still pretty elusive.
Yeah, it shows how medicine evolves, doesn't it? And it tends to hit a specific group.
It does. Mostly young women, typically in their 20s, maybe 30s. And while you see it worldwide, it's definitely more common in Asia.
Okay. So deep history, specific target in the body, specific demographic, but still some question marks around why it happens.
That sums it up pretty well. So our plan today is to walk you through the key parts of TA, how it was first recognized, what it actually does to the body, how doctors figure it out, and the treatments available now.
Connecting the dots, basically. Okay, let's start with that history. Sounds like the first whispers were a long, long time ago.
Oh, yeah. Way back. You can find notes from 1761, an Italian physician, Morgagni. He did a lot of autopsies and described people with, well, really changed large blood vessels, big bulges, aneurysms, and narrow spots, stenosis.
So anatomical clues not really linking it to a specific disease yet.
Exactly, just observations. Then jump to 1830, Japan. A physician named Yamamoto described a patient, had a fever, and then about a year later developed this really striking thing, no pulses in his arms.
Pulselessness, that sounds pretty specific.
It does. But the real turning point, the name, comes from another Japanese physician, an ophthalmologist, Mikito Takayasu, in 1908.
Ah, the namesake.
Right. He presented findings at a meeting, a young woman with sudden vision loss, absent pulses in her wrists, and these unusual artery vein connections in her retina, really specific findings.
And he wasn't alone.
No, that's the fascinating part. At the same meeting, two other eye doctors reported patients with similar vision issues and, crucially, those absent radial pulses, too.
Wow. So multiple people seeing the same pattern independently.
Exactly. It really started to solidify the idea of a distinct illness. Then, fast forward a bit to 1939, Yasuso Shinmi, another Japanese doctor, actually proposed the term Takayasu Arteritis for a patient with similar symptoms and findings.
So the understanding shifted, it sounds like, from just seeing damaged vessels to recognizing maybe an inflammatory process behind it.
Precisely. It highlights how hard it can be to diagnose something just based on the late-stage damage.
But the name Takayasu Arteritis didn't stick right away.
No, it took quite a while, actually. It wasn't formally adopted until 1975 by a research committee in Japan's Department of Health and Welfare. Just shows how medical understanding and terminology evolve, It takes time and evidence.
Okay, that sets the historical stage. Now let's look at who gets this and where. The epidemiology, what does that tell us?
Well, there's quite a bit of geographic variation. Japan, for instance, has around 150 new cases a year. And interestingly, autopsy studies there suggest a prevalence maybe as high as 1 in 3,000.
Which might mean it's underdiagnosed. Or maybe some cases are really mild.
Could be either, or both. Compare that to India, though, where estimates are much higher. Maybe 200 to 300 cases per million?
Huge difference.
It is. And then you look at somewhere like Sweden, it's way down at maybe 0.8 per million incidents. Or Birmingham, England, even lower, 0.2 per million. Even within the U.S., like in Olmsted County, Minnesota, it was found to be 2.6 per million.
So it varies a lot, even within continents.
Absolutely. And this variation, plus the fact it hits young women more often, strongly suggests, well, a complex mix of genes and maybe environmental triggers. But nailing down those triggers is still a big research question.
And that gender skew is really pronounced, right?
Oh, definitely. It's a hallmark. Overall, women are affected maybe 6 to 8 times more often than men, but even that ratio varies. Yeah, like in India, studies show closer to 4 to 1 women to men. In China, maybe 3 to 1. So while female hormones might be involved somehow, it's clearly not the whole story. Other factors must be at play.
And age. Mostly young adults, but not exclusively.
That's right. The peak onset is typically between 20 and 40, but, with better diagnostics and awareness, we're recognizing it can definitely start later in life, too. A big NIH study found the median age at diagnosis was 25, but it's not strictly limited to that window.
Okay, so the pattern's Asia. Young women point towards genetics, maybe interacting with something else, which leads us nicely into the pathogenesis. What's actually going wrong biologically?
Yeah, the why. It's almost certainly multifactorial. Genetics seems key, given the higher rates in Asia, especially Japan, and you sometimes see it run in families, though that's rare.
Are there specific genes linked to it?
Yes, researchers have found some associations. There's a particular immune system gene marker, HLA-BW52, that's found much more often in Japanese patients with TA, like 44% versus 13% in the general population there.
Okay, that's a significant difference.
It is. And even more specific, a combination of genes called the BW52DW12 haplotype seems linked to more active inflammation and faster disease progression in those patients. Other HLA regions are also implicated in some studies.
So these HLA genes, they're like the immune system's ID tags, helping tell self from non-self.
That's a good way to think about it, and certain variations in these tags seem to make people more susceptible.
But these genetic links aren't the same everywhere.
That's a really important point. Studies in North American patients haven't found such strong links between specific HLA types and, say, how severe the disease is. Actually, one study found a negative association with HLA-DR1, suggesting it might even be slightly protective in that group.
Huh. So it's complicated. Different genetic factors might be important in different populations.
Exactly. It really underscores the complexity.
Okay. Beyond genetics, what about the immune system itself? It is an immune arteritis.
Right. Immune mechanisms are definitely central. The fact that TA sometimes pops up alongside other autoimmune conditions like rheumatoid arthritis, lupus, inflammatory bowel disease, even some kidney inflammation suggests, shared pathways where the immune system goes awry.
And wasn't there some thought about a link with tuberculosis? The T?
Yes, that's come up.
Yeah.
TI causes a type of inflammation called granulomatous inflammation, and TB does too. So, especially in places where TB is common, researchers looked for a link. But
No direct proof.
right. No definitive cause and effect found. It's more like a correlation that needs more investigation. Maybe TB could be a trigger in someone already susceptible, but it's not proven as the cause.
Got it. So what specific immune cells are thought to be doing the damage?
There's good evidence for cell-mediated damage, meaning specific immune cells attacking the blood vessel lining, the endothelium. Certain T cells, called gamma-delta T cells, seem overly reactive to a protein called HSP60 in TA patients, and they've been shown to directly damage aortic endothelial cells.
How do they do that?
Seems to involve releasing a signaling molecule, interferon gamma. That might be a key part of the inflammation in TA, possibly different from other related diseases.
And antibodies. Are they involved too?
Yes, definitely evidence for antibody involvement. TA patients often have high levels of antibodies that target their own aortic endothelial cells.
Autoantibodies.
Exactly. These anti-aortic endothelial cell antibodies can trigger a cascade, making cells stick together, releasing inflammatory proteins called cytokines, and ultimately causing those endothelial cells to undergo apoptosis, or programmed cell death.
And you mentioned the levels are high.
Significantly high, like maybe 20 times greater than in healthy people, and even higher than in folks with other autoimmune diseases.
Wow, 20 times. That really hammers home the immune attack, doesn't it?
It really does.
Okay, back to the young women aspect. Any role for sex hormones?
It's a strong hypothesis, given that striking prevalence difference. Some studies found higher estrogen levels in the urine of women with TA compared to healthy women. And interestingly, there's an association between TA and Klinefelter syndrome.
Which is a condition in men.
Right, where they typically have higher estrogen levels. So that connection adds a bit more weight to the idea that the hormonal environment might play a role in susceptibility.
So pulling it together on pathogenesis, it sounds like a perfect storm. You've got maybe a genetic predisposition, then the immune system gets dysregulated, starts attacking vessel walls, maybe influenced by hormones. It's a lot.
Precisely, a complex puzzle, and researchers are still fitting the pieces together.
Okay, let's shift from the why to the what. What does this inflammation actually do to the blood vessels? What does the pathology show?
When you look at the tissue under a microscope, you see this panarteritis.
Pan meaning all.
Right, inflammation across all three layers of the vessel wall. Intima, media, adventitia. But a key feature is skip areas.
Skip areas, like jumps around.
Kind of. Segments of the vessel are inflamed, but right next to them, you might find relatively normal-looking segments. It's not a continuous inflammation along the whole length.
Patchy. Got it.
Exactly. And the inflammation itself can look different depending on the stage. It might be acute, with lots of immune cells rushing in, lots of fluid, like a sudden reaction. Or it can become chronic, with more tissue thickening and scarring. And sometimes you see those granulomas organize clusters of immune cells.
Where does the inflammation usually start?
It often seems to begin in the vasa vasorum, those tiny little vessels that actually supply blood to the walls of the big arteries. From there, it spreads outwards through the media and adventitia, leading to fibrosis or scarring.
And the inner lining, the intima, what happens there?
You get thickening there too. Cells like smooth muscle cells can multiply and move into that inner layer, laying down extra connective tissue. This intimal thickening is a major reason the vessel lumen, the space inside, gets narrower, especially in smaller branches. And that narrowing leads to ischemia, not enough blood flow.
What about the structural parts, muscle and elastic fibers?
Yeah, using special stains, you can see that in the inflamed areas, those crucial muscular and elastic layers get damaged and replaced by dense scar tissue. And deep within the wall, you often find these nodules packed with immune cells, T cells, B cells, dendritic cells, all interacting. It suggests a really active immune process going on right there in the vessel wall.
So in the long run, the chronic phase, what are the lasting effects?
Permanent thickening of the whole wall. The lumen gets narrower because of that intimal buildup. The elastic fibers in the middle layer get destroyed, so the vessel loses its stretchiness, and the outer layer gets stiff with fibrosis. All adds up to reduced blood flow.
And aneurysms, we mentioned those earlier. How do they fit in?
Right, the bulges. They happen, though, generally less often than the narrowing, the stenosis. The thinking is that an aneurysm forms when the inflammation destroys the elastic parts of the wall before significant scarring builds up in the outer layer. Without that structural support, the weakened wall balloons out under blood pressure.
Okay, that gives a clear picture of the damage. Now, how does this actually show up for a patient? What are the clinical signs and symptoms?
Well, the classic idea used to be these three phases. An early inflammatory phase with general symptoms like fever, aches, then a phase where the vessels themselves hurt, and finally a burned out phase with scarring and maybe aneurysms.
But it's not always that neat.
No, not really. We now understand it's much more diverse. Patients don't always follow that sequence. Some might have inflammation and scarring happening at the same time. Some might not even have many systemic symptoms early on or ever.
So that old phase model is a bit too simple.
Yeah, the reality is more complex, which leads to a huge range of possible symptoms.
And those early vague symptoms must make diagnosis tricky. Things like fever, headache, weight loss, aches.
Exactly. They're so nonspecific, it often leads to significant delays in diagnosis. People talk about a median delay of maybe a year, sometimes longer. And patients often see multiple doctors, maybe 5 on average, before they finally get the right answer.
That must be incredibly frustrating. A year of feeling unwell and bouncing between doctors.
Absolutely. And a physical exam early on might not show much either.
So normal exam doesn't rule it out.
Correct. Though certain findings can raise suspicion. Interestingly, what doctors find most often can vary by region.
Like what?
Well, carotid bruits, that whooshing sound over the neck arteries, seemed more common in North America and Italy. Absent pulses were more the hallmark in Mexico. High blood pressure was a big one in India.
So where the inflammation hits determines the signs.
Precisely. It can affect arteries almost anywhere, leading to different problems depending on the location, vision issues, arm pain, high blood pressure, heart problems. It's very variable.
Let's break down some key areas. Cerebrovascular arteries to the brain. What happens there?
Several things. You can get carotidynia pain along the carotid artery in the neck. Maybe a third of patients have that. Fainting or feeling like you're about to faint. Syncope or pre-syncope is also common.
And more serious stuff. Stroke?
Yeah, unfortunately. Stroke, TIAs, mini strokes, or temporary blindness called amaurosis fugax can happen in maybe 5% to 20%. And vision problems in general are pretty common, up to 30%. Often linked to reduced flow in the vertebral or carotid arteries. There is even a specific pattern called Takayasu's retinal disease.
And the arms, the pulseless disease connection, that's common.
Very common. Weak or absent pulses in the arms are found in, well, a lot of patients, somewhere between 50% and nearly 100%, depending on the study. Claudication pain with activity is actually more frequent in the arms than the legs, maybe around 60-something%.
Why the arms more than legs?
Often because the left subclavian artery supplying the left arm is a common target. There's also something called subclavian steal syndrome, where blood gets shunted from the brain to the arm, but it was thought to be rare in TA. Now, though, we see that isolated disease just at the start of the subclavian is pretty common.
Okay. What about the heart itself?
Yep.
Cardiac involvement.
That's a significant concern, too. The coronary arteries supplying the heart muscle can be affected in maybe 6% to 16%, leading to angina or even heart failure.
And the valves?
Yeah, aortic valve regurgitation, where the valve leaks, happens in 12% to 24%, usually because the base of the aorta, the root, gets dilated or widened. That seems more common in India. The mitral valve can leak too, but less often, maybe 3% to 11%.
Pulmonary arteries to the lungs.
Surprisingly common, it seems. Angiography studies suggest maybe up to 70% have some involvement, which can lead to pulmonary hypertension, high blood pressure in the lungs. And rarely, the heart muscle itself can get inflamed myocarditis, causing heart failure symptoms even without blocked coronaries or bad valves.
And high blood pressure, hypertension you mentioned, that's frequent.
Very frequent, seen in maybe a third to 60% of patients when they're diagnosed. But, tricky point, if you have narrowing in both subclavian arteries in the arms, the blood pressure reading in the arms might be falsely low.
Ah, so it could mask the real hypertension.
Exactly. A major cause of the hypertension is narrowing of the renal arteries, the ones going to the kidneys. That happens in 20% to 50%, often affecting both sides, right where they branch off the aorta.
But you can have high blood pressure even without kidney artery problems.
Yes, in maybe 5% to 30%. That could be due to something called middle aortic syndrome, or just the aorta being less stretchy, or problems with the blood pressure sensors in the neck. Middle aortic syndrome is this long narrowing in the descending aorta. It often causes a bruit, a whooshing sound, and carries a worse prognosis if untreated.
What about the gut, the visceral arteries supplying the intestines?
They can be involved in, say, 3% to 31% of patients. But interestingly, symptoms of mesenteric ischemia, like bad abdominal pain from lack of blood flow, are actually pretty rare. Surgery there is tricky because the inflammation often goes through the whole vessel wall.
And the legs, less common than arm symptoms.
Generally, yes. Leg claudication occurs in maybe 24% to 32%. The iliac arteries supplying the legs are involved in about 20%. But often, the leg symptoms seem related more to narrowing higher up in the abdominal aorta rather than blockages in the leg arteries themselves, which are less commonly hit.
Okay, and aneurysms again. You said the frequency varies a lot by location.
Yeah, big time. Some studies from South Africa reported very high rates in surgical patients, like over 70%. North America, maybe around 27%, often in the aortic arch. India and Italy reported lower rates. Japan higher again, often multiple aneurysms mixed with narrowings.
Do they rupture easily?
Generally thought to be a lower risk than, say, atherosclerotic aneurysms, but they can rupture, and often in younger people. And beyond just blood flow issues, patients can get other things like Raynaud's phenomenon, fingers changing color in the cold, or skin problems like erythema nodosum or rashes.
Wow. Okay, so the presentation is incredibly varied, which must make diagnosis a challenge. How do doctors diagnose it?
It's definitely a puzzle sometimes. Diagnosis relies on putting together the clinical picture, lab tests showing inflammation, and crucially, imaging to actually see the affected arteries. There isn't one single magic test.
Are there diagnostic criteria?
Several sets have been proposed over the years. Ishikawa's criteria included being under 40. The American College of Rheumatology, the ACR, removed the age limit in 1990 and listed 6 features, needing 3 of them gave pretty good accuracy. Then Sharma modified Ishikawa's, trying to catch it earlier and account for geographic differences, using major and minor criteria.
But no single global standard.
Not really. The main thing is ruling out other things that can affect blood vessels, other types of vasculitis, infections, fibromuscular dysplasia, stuff like that before landing on TA.
What about blood tests? Any specific markers?
Unfortunately, no specific diagnostic blood test, but tests can show general inflammation. Anemia is common. ESR and CRP, the erythrocyte sedimentation rate, and C-reactive protein are the main inflammatory markers used.
Are they reliable?
They're helpful, but not perfect. ESR is often high at diagnosis, maybe 70-odd% of the time, but it can stay high even when the disease is quiet, or be normal even when it's active, so you can't rely on it alone. CRP is used too. Other markers like IL-6, RANTES, MMPs are being studied, but a big review in 2018 by EULAR concluded ESR and CRP are still the most practical tools we have right now for tracking inflammation.
So imaging sounds absolutely key then, seeing the vessels.
Absolutely critical. Historically, the gold standard was digital subtraction angiography, DSA, basically an X-ray with contrast dye.
But that's invasive.
Right. So now non-invasive methods are much more common. Duplex ultrasound, CTA, computed tomography angiography, and MRA, magnetic resonance angiography. These can see not just the narrowing inside, but changes in the vessel wall itself, sometimes before major narrowing happens.
What's best now? MRI.
MRI, specifically MRA, is often considered the new gold standard by many, including those 2018 ELAIR guidelines. It's non-invasive, no radiation, and gives great detail on wall inflammation and the lumen.
How does it show inflammation?
You often see the vessel wall enhance or light up after giving contrast dye, which correlates with active inflammation. Certain MRI sequences can also show edema or swelling in the wall. It's not perfect sometimes. It overestimates blockages, or you might see edema even in remission. But it's a powerful tool. There are even newer contrast agents being tested to better show active versus inactive disease.
And CT scans.
CTA. CTA is also very useful. It can show thickening and enhancement of the vessel wall, sometimes even calcification. It's great for seeing the overall extent of the disease, often showing the wall inflammation is more widespread than the narrowing inside suggests. It can pick up those skip lesions too and show active and inactive areas coexisting. It correlates well with angiography, but often gives a broader picture.
What about P scans?
PET scans, using that radioactive glucose tracer, 18-FDG, are really good for spotting active inflammation. Inflamed areas are metabolically active and suck up the tracer, so you can see inflammation even before significant narrowing develops. It's useful for diagnosis, monitoring treatment response, seeing if the uptake decreases, and finding unexpected active spots. Studies show good accuracy for assessing activity.
So it sounds like using a combination of these imaging techniques gives the best picture. Does angiography still have a role?
Yes, conventional angiography still has its place. It gives the most detailed map of the narrowings and aneurysms. It's essential for planning and guiding endovascular treatments like stenting. And sometimes measuring pressure directly inside the aorta during the procedure gives important info. Plus, those classification systems we'll touch on are often based on angiographic findings.
Right, classification. Seems like there are a few different ways to classify TA. Why so many?
Yeah, it reflects our evolving understanding. Early systems like Ueno's focused just on which parts of the aorta were involved. Lupi Herrera added a type for pulmonary artery involvement. Nasu refined Ueno's system. And then 1994 Tokyo Conference proposed 6 patterns, even adding codes for coronary or pulmonary involvement.
So trying to capture the different ways the disease presents anatomically.
Exactly. The variety of systems shows how diverse TA can be, and maybe that no single system perfectly captures everything for predicting outcomes or guiding treatment yet.
And classifying disease activity, how active the inflammation is, that seems crucial for treatment.
It is crucial, but also really challenging. There's no single perfect definition. Early ideas used ongoing steroid use as a marker, but that's flawed. You can be active on steroids or quiet off them.
Oh.
So more complex definitions came along. The NIH definition looks for new or worsening features like systemic symptoms, high ESR, new vascular signs, or changes on imaging. The Mayo Clinic criteria are similar, but might use CRP or even require seeing active inflammation on a biopsy.
Which might mean needing surgery just to confirm activity.
Sometimes, yes. So it's still an area where standardization is lacking, making it tough to compare studies or guide treatment perfectly.
Okay, huge amount covered there. Let's get to treatment. How is TA managed medically?
Well, first off, maybe 10–20% of patients might have a self-limiting course and not need long-term immunosuppression. But for most, suppressing that inflammation is key.
Starting with steroids.
Usually, yes. Glucocorticoids like prednisolone are first line, typically started at a fairly high dose to knock down the inflammation quickly, then tapered down slowly over months, aiming for a low-maintenance dose, maybe under 10 milligrams a day after a year, if possible.
Does that work for everyone?
The response varies a lot. Some get great remission, others not much improvement. One big study, the NIH cohort, found about 60% got remission with steroids at some point. For the rest, adding other immunosuppressants helped about another 40%.
But relapse is a big issue, right? The disease coming back.
A huge issue. Relapse rates are high, reported anywhere from 45% up to over 90% in some studies, even after initial success with steroids.
Wow, that's incredibly high.
It is. And because of that, and the side effects of long-term steroids, other immunosuppressants are often added, things like methotrexate, azathioprine, mycophenolate mofetil, sometimes cyclophosphamide. In fact, those 2018 EULAR guidelines is just considering adding one of these conventional agents for pretty much all TA patients now.
To try and maintain remission and reduce steroid dose?
Exactly. But even with these combinations, sustained remission can be tough. Some studies show maybe only a quarter or so achieve long-term drug-free remission, and some patients have ongoing active disease despite trying multiple therapies.
Which leads to looking at newer options, refractory therapy.
Right. For those tough cases, the biologic agents have become important. Anti-TNF drugs like infliximab or adalimumab, an anti-IL-6 drug, tislelizumab, and sometimes rituximab, which targets B cells.
Have these shown promise?
Yes, quite a bit in refractory disease. Anti-TNF therapy can help induce remission and allow steroid reduction. Tocilizumab also looks effective, maybe comparable to anti-PNF in some studies. Rituximab has been used successfully when other things haven't worked. The EULAR guidelines specifically back using tocilizumab or anti-TNF for refractory TA.
Okay, so medical therapy is the foundation. But what about fixing the damage, the narrowed or blocked arteries? When do interventions like surgery or stenting come in?
The need for revascularization varies. It seems more common in places like the US and Italy, less so in Japan or India, based on reports. Ideally, you want to do these procedures when the disease inflammation is quiet.
Why?
Active inflammation seems linked to worse long-term results. Grafts might fail sooner, you might need more procedures later. But confusingly, sometimes tissue removed during surgery from patients thought to be in remission still shows active disease under the microscope. It's hard to be certain.
So when is it indicated?
Generally for things like severe hypertension from renal artery stenosis that meds can't control, really bad limb ischemia limiting lifestyle, symptoms of poor brain blood flow from neck artery narrowing, significant aortic valve leakage getting worse, chest pain from coronary narrowing, severe aortic coarctation, or aneurysms that are growing or dissecting.
Let's talk about endovascular options first. Angioplasty, stenting, PTA.
Yeah, PTA and stenting. Initial results often look good. You open the vessel up. But the long-term picture is often less encouraging in TA compared to, say, atherosclerosis. There's a high risk of restenosis, the vessel narrowing down again over time.
Why is that?
It might be the nature of the vessel wall in TA. It's fibrotic, stiff. The narrowings are often long and irregular. Stable disease activity and being on immunosuppression seem to help keep things open longer. But major studies showed pretty frequent restenosis and need for repeat procedures or bypass after just PTA. Stent grafts, covered stents, might offer slightly better results than bare metal stents or PTA alone. But we need more data.
Okay, so endovascular has limitations. What about traditional open surgery? Bypass grafts.
Open surgery has been the mainstay for severe blockages causing significant problems. For instance, carotid bypass to prevent stroke, often using the aortic arch as the starting point for the graft. Similar bypasses for bad subclavian or axillary artery disease in the arms.
In the heart.
Coronary artery bypass grafting, CBG, works well for blocked coronaries in TA. If the aortic root is dilated, causing valve leak, aortic valve replacement might be done at the same time.
Kidneys.
Renal artery bypass is often done after failed stenting or sometimes first line for complex disease. Usually uses the aorta or another nearby artery for inflow, and ideally uses the patient's own vein or artery for the graft. It can significantly improve blood pressure, kidney function, and patency seems pretty good.
What about that middle aortic syndrome?
Open surgery is really the gold standard there. Often needs an aorto-aortic bypass going from above the narrowing to below it, often down to the iliacs. Usually gives great improvement in hypertension.
And fixing aneurysms.
Open repair is more common than endovascular for TA aneurysms, partly due to limited data on endovascular repair in this specific setting. One tricky thing after open aneurysm repair in TA is a higher risk of developing new aneurysms, where the grafts are sewn in anastomotic aneurysms. Doesn't seem directly related to inflammation levels or steroid use, interestingly.
How safe is open surgery overall in TA?
In experienced centers, the reported risks are generally low, and long-term patency of the bypasses is often quite good. Late deaths, when they occur, are often due to heart failure.
So how do endovascular and open surgery compare directly? Any head-to-head studies?
Not many large randomized trials because TA is rare, but retrospective studies and meta-analyses give some clues. One study suggested higher overall vascular complications with endovascular. A meta-analysis found higher restenosis rates with endovascular regardless of disease activity, particularly in coronary, supraortic, and renal arteries.
Any difference in major risks like stroke or death?
Stroke seemed maybe slightly more common with open surgery, especially for the supraortic vessels. But overall mortality and other major complications look pretty similar between the two approaches in that analysis. The bottom line is anyone needing revascularization needs really close long-term follow-up.
Okay. Are there special things to consider for specific groups like pregnant women or children?
Yes, definitely. Since TA hits young women, pregnancy is a big consideration. Encouragingly, large centers report many women with TA have healthy pregnancies.
That's good news.
It is. Though there might be a slightly higher risk of disease flare-ups or miscarriage, really poor outcomes seem linked more to pre-existing problems like severe hypertension, aneurysms, heart failure, just very extensive disease.
Hmm.
Some studies even suggest pregnancy might temporarily improve inflammation markers. Importantly, pregnancy itself doesn't seem to worsen the long-term course of TA.
And kids, it can happen in children too.
Yes, even infants. Maybe 13% to even over 70% of cases start before age 20, depending on the report. Diagnosis is tough because the initial symptoms are so vague in kids. The aorta, thoracic, and abdominal is often involved. Ischemic symptoms might be less common than in adults. Hypertension is often the main presenting sign in kids. Medical treatment can work well, maybe achieving remission in half the cases in one large Chinese series. Imaging is absolutely key for diagnosis in children.
Finally, then, what's the overall long-term outlook, the prognosis?
It's generally considered guarded. It starts young, can be chronic and progressive, even with treatment, impacting all parts of life. Relapse is common, as we said.
Are there factors that predict a worse outcome?
Yes, the 2018 EULR group identified things like having major complications already at diagnosis, being older at onset, having a progressive course despite therapy, and maybe, paradoxically, having a weaker initial inflammatory marker response.
What about survival rates?
One study reported about an 83% survival rate at 15 years, but it was lower for those with major complications or progressive disease. Congestive heart failure is a major issue and the most common cause of death.
Okay, so bringing this deep dive together,
Yeah.
we've really covered a lot of ground on Takayasu Arteritis. It's clearly a complex, chronic inflammatory condition. Fascinating history.
Absolutely. And those diverse ways it presents make diagnosis a real challenge, requiring these multifaceted management approaches we've discussed. We've seen it's likely this mix of genes, immunity, maybe hormones, and definitely needs more research to figure out the exact why and find even better treatments.
Still, it's impressive how far understanding has come. From those early descriptions centuries ago to modern imaging and targeted immune therapies today.
Definitely. But we always have to remember the significant impact this has on people's lives, especially starting so young. Improving diagnosis, treatment, and long-term outcomes remains critical.
So let's end with a final thought for you, our listeners. Given just how much Takayasu arteritis varies from person to person, and this ongoing search for better, less invasive diagnostic tools, how might personalized medicine change things in the future? Could things like detailed genetic profiling or finding really specific biomarkers help us understand TA better and maybe tailor treatments much more effectively down the road? Something to ponder beyond our discussion today.